Good morning, all. Today I will be presenting on the novel immune signatures and inflammatory profiles associated with types of cataract. I have no financial interests. Till not very long ago, cataractogenesis was thought to be due to oxidative stress and osmotic stress, which eventually led to lens protein modification and aggregation. But what if the altered immune profiles that play a role in cataractogenesis and more specifically in different types of cataract? Based on a few studies done on animal models, we asked ourselves if there are any molecular factors altered in eyes with different types and grades of cataract, and if they were proportionate with the cataract types and grades. Till recent times, the adult lens was thought to be an immune-privileged structure protected from inflammatory responses, as it is not associated with any vasculature. However, it has now been established that novel pathways exist by which the immune cells associate with the lens to protect, maintain homeostasis, and repair it. The lens harbors a population of tissue-resident immune cells, which are often seeded during the early lens development phase. Studies reveal that the ciliary body is the principal source of lens-resident immune cells. After cataract surgery wound, these activated immune cells proliferate and rapidly populate the wound edge. These cells secrete CD44, CD45, CD14, MHC2, and most importantly, vimentin and integrin. This study by Ehsan et al. Identified two distinct routes of immune cell trafficking in the eye pertaining to the cataract formation. The main route originates in the ciliary body and the alternate through the pre-retinal conical structure or its immediate vicinity. In our study, we included all cataract eyes and were subdivided into groups depending upon the grade. Aqueous humor was collected during standard of care cataract surgery. The cell-free part of the aqueous humor was used to measure the soluble factors like cytokines, chemokines, and growth factors. And the cells in the aqueous humor were measured using immunophenotyping. Coming to the results, out of the multiple immune inflammatory factors measured, the levels of vascular endothelial growth factor A, interleukin 6, and interleukin 17 were significantly raised. Both interleukin 6 and interleukin 17 levels were significantly raised in nuclear sclerosis of grade 3 to 4 with posterior subcapsular cataract. Higher levels of leukocytes, total neutrophils, and activated neutrophils were observed in posterior subcapsular cataract alone. However, monocytes, cytokine-producing NK cells, and T cells were higher in nuclear sclerosis along with posterior subcapsular cataract. These findings demonstrate that cataract type-specific immune cell and inflammatory factors diversity is present. Our study adds that the immunoinflammatory profile of posterior subcapsular cataracts is distinct from other types, underscoring the importance of immune-mediated mechanisms in cataractogenesis. The variations in inflammatory markers and immune cell populations suggest that cataracts are not merely a result of aging, but also involve active immunological processes. Identifying specific immune signatures in different types of cataract may enable targeted anti-inflammatory therapies to slow cataract progression, personalize surgical management to minimize postoperative complications, and better prognostic tools for assessing the risk of post-surgical inflammatory responses. Finally, a larger cohort study to validate our proof of concept data and further studies exploring the mechanistic pathways of inflammation in cataractogenesis, which may pave the way for novel therapeutic interventions which ultimately improves the patient outcomes in cataract surgery is required. Thank you.
So we all know that cataract is also age-related versus the posterior subcapsular, which you told is a result of inflammation, drug-induced, other things. So what was so specific regarding, because we all know that cataract is due to inflammation, uveitis, diabetes, and so other things, especially in posterior subcapsular. So one thing we came to know that there are certain markers which are more so are present there, which anyway we thought that these are, for example, in diabetes or inflammation or in uveitis, they would be there. So any specific thing in your study which told that in relation to nuclear and cortical cataract, which are usually age-rated, you find that some sorts of markers were more present in nuclear and cortical cataract?
So, first of all, in our study, we have excluded all patients with diabetes and complicated cataracts. These are all only plain age-related cataracts, and we have not included any cataract which is due to any uveitis or retinal disorders or any patients on any systemic diseases. So that rules out any confounding factors. And in these patients with only cataracts, age-related cataracts, we have found that there is significant increase in immune cells and inflammatory markers in posterior subcapsular cataract, which are not as increased in other types of cataract.
So any particular reason for increase in immune cells in such kind of patients? Could you make it out? It was just age-rated only.
Yes.
Actually, in posterior subcapsular cataract, even if there is no evident manifest pathology, generally it is assumed that posterior subcapsular tends to be secondary to some underlying condition which may not be manifest, which may be subclinical. So I think it stands to reason your
Yes.
study supports that.
Yes, sir.
And like you said, this is just the initial thing, and probably it can lead on to
More
further
studies,
studies,
yes.
and then let's see how things work. But good presentation. Thank you.
Thank you, sir.